Hello and welcome to Season 2, Episode 22 of the Physician Assistant Exam Review Podcast. This week, we're going to be covering AFib and A-flutter, two atrial arrhythmias. Hello, my name is Brian Wallace. Welcome aboard. Thank you so much for coming. I am the host and creator here at physicianassistantexamreview.com. Over at the website, you can find the notes for all of the shows. If you are more of a visual kind of person, a lot of people like to follow along as they listen right on the website, or else you can take it on the go in the car on your run, as lots of people point out to me that they can squeeze in some extra studying or learn some new things while not sitting at a desk, which is really the best thing. For me anyway. I struggle to learn anything while sitting at a desk. So hopefully you've got some other activities going on. You can keep this running and it can help you squeeze in as much setting as you can get. I know it can be difficult. So a lot of the couple things to cover. It's been a busy week. I screwed up last week and didn't get the show out. So I saved this episode for this week. Those of you listening to me in the future won't even notice because this one will just show up right after the one before it, after 21. But those of you who are following along week to week, I know that there was a blizzard, while it was supposed to be a blizzard on the East Coast. I live just north of Philadelphia. We were supposed to get 12 inches of snow overnight, lasting, being the worst part of the time, being from 4 in the morning to 6 in the morning, which is, I generally leave for work about 6:30. So I wound up staying overnight at the hospital. We had a couple of cases, most of our stuff canceled, but we had a couple of cases that went through, and for good reasons. Those people were anticipating their surgery for very good reasons. I'm not going to go into details as to the how and the why of that here today, but we got those taken care of. That being said, that was my rather poor excuse for not having recorded the show early in the week and gotten that taken care of and done. So I slept over at the hospital, got up, got the workday done, came home, shoveled, and was exhausted and just simply didn't get to it. All of that being said, this is really to set me up to explain that that's going to continue to happen as we move into baseball season. This week, except for the snow that's still on the fields, this week was supposed to be week 1 of baseball. I am currently coaching 3 different Little League teams. My 2 sons play on a total of 4 teams, so I'm helping out with those, which is my absolute favorite thing to do. So I'm going to be coaching 3 teams, working full-time, and putting out this show, all to with the end point here being that the show generally goes out on Tuesday mornings at about 6 o'clock in the morning, is very typically when you can find new episodes. However, but until the beginning of June, that may be less consistent, not as consistent as it typically is. So just be aware, nothing's wrong. There's no problem. I'm still doing the show. I get emails when I miss things, and the people say, "Hey, is everything okay?" So I'm just giving out that preemptive. From now till June, there may be a little delay in some of the episodes. They may come out on Thursdays. They may come out not till the following week. You'll see how it goes. Let's see. What else I want to talk about? Well, a couple people passed this week, and I wanted to briefly congratulate them. Katie passed her exam, MJ passed, and Shirley wrote in saying that she passed. I also wanted to point out or talk briefly about Brooke emailed me actually just today saying that she passed her exam and she had failed her PANCE the first time around, so she was super excited. What did she say here? I just want to let you know that I just received my score for the PANCE second time, and I passed with an increase of 137 points. Your final step book and review binder, as well as Andrew Reed's course, played a big part in my preparation, and I wanted to thank you. Also, one of the ideas from the Maximize Your Time course played a huge role and definitely stopped me from panicking like I did on the first time. So thank you to Brooke. That's excellent. I've also been pointing people towards, so as much as she used the final step and the Maximize Your Time course, I know that those really helped. I've also been pointing people a little bit towards Andrew Reed stuff. I'm in touch with him frequently, although I unfortunately, I don't have enough time to review his stuff. The stuff I have reviewed, I'm a big fan of. I like it a lot, but I just haven't had time to go through a lot of it. I recently sent out, he's doing a pharmacology course. And so I just don't have a lot of stuff on farm, and the free stuff he put out, I did get a chance to review, and it was really good. Some worksheets, some cheat sheets. So I sent some people over there and said, go check this out, take a look at this. Make sure you look at his stuff. Like I said, I can't vouch for all of it. I have not been through all of it, but I will say that he generally puts out good material. He's very interested in what he puts out and helping people. And he's been doing it for just not quite as long as I have. I think he started a year or two after me, but he's been doing it for a while. We've been in touch most of that time. and he usually puts out good stuff. And like I said, if you're struggling with farm, go check out his new farm course. I'm hoping it's really good because we definitely need something in that market for you guys. All right, so I think that's about it. Let's jump in to get started, and where we always start. Oh, you know what? I was going to do things a little bit differently this week. Let's go back a little bit to let's talk about atrial arrhythmias first of all. So we talked a little bit last week. Or actually, it wasn't last, it was 2 weeks ago, in last time anyway, about the conduction system of the heart. We talked about the SA node, which is the pacemaker, the AV node, which is stimulates from the atria to the ventricles. We talked about 60 to 100 being the normal heart rate for the SA node, and 40 to 60 being the normal rate for the AV node, right? We're remembering to hold on to that stuff. Repetition. I'm repeating all this stuff. Probably should have put this in as questions at the beginning, but I didn't. So anything over 100 was sinus tach. We remember all that. Paroxysmal supraventricular tachycardia, we covered that. That was above the ventricles, right? Supraventricular, and it's going to have a narrow QRS. Ventricular arrhythmias will have a wide QRS, which we'll cover next week. What else did we cover? That was pretty much it. So we did a little introduction to conduction system of the heart and some supraventricular arrhythmias. Today I'm going to continue with supraventricular arrhythmias and talk about AFib and a flutter. So let me bring that section of my notes up and make the layout so I can view it appropriately. All right, so now that we did our short little review there, let's go through some of our priming questions for AFib and a flutter. And number one, what's a classic ECG finding for atrial flutter? Classic ECG finding for a flutter. It's that sawtooth waves. Is AFib regular or irregular? You check somebody's pulse. Will AFib be regular or irregular? It will not only be irregular, it will be irregularly irregular. We'll cover that in a little bit. Is a flutter usually regular or irregular? If you check somebody's pulse and they're in a flutter, is it going to be regular or irregular? Usually it'll be regular, although it could be irregular. But generally speaking, I would go with regular and keep an eye out for that, although it's not going to be a defining characteristic of a flutter. It's generally going to be regular. All right, so let's jump in and talk about AFib. Atrial fibrillation. Fibrillation is a muscular twitching involving individual muscle fibers acting without coordination. Now, this is the key here, and it's kind of a simplification. You don't need the ridiculous detail on this. It's muscle fibers that are twitching without coordination. So what happens is you get the atria that would normally be in coordination. So you get the SA node fires, and then the muscle fibers of the atria then get that electrical conduction through them, and they all contract together. So it's very much a coordinated effort. In AFib, you don't get that coordinated effort, not at all. You get each muscle fiber sort of randomly firing and randomly contracting, and so what you get essentially is a quivering of the atria. So they're not basically doing anything of much value. They're not contributing to pushing blood through the heart. The atria are just sort of quivering as each muscle fiber contracts individually and sends out its own signal about when to contract to the other fibers, and it sort of just circles through, and you don't get a lot of actual effort out of the heart. This is most common during this is the most common chronic arrhythmia, and it usually starts out as PSVT before becoming chronic. Now, the first time someone goes into AFib, the first time their heart does that, they'll convert back to normal about 60% of the time in the first 24 hours. So that first time it'll often break its own cycle and go back to a normal rhythm about 60% of the time in the first 24 hours. But after that, those chances drop. Risk factors for AFib. So I need you to picture in your head, before we get to the risk factors, just picture that heart quivering. That is atria just quivering and not really putting out any good contractions, not helping push blood through the heart. Just the blood sort of sitting in those atria, sort of pooling up, because that's obviously our major concern, is creating a clot in those atria and then having an embolic event, which we'll talk about in a little bit. Risk factors. These can occur, AFib can occur without any risk factors at all, first of all, so there can be no risk factors. Chronic hypertension is a good risk factor. I would definitely put a little star next to that one. Coronary artery disease, valve disorders, and hyperthyroid is another good one. Just easy to ask test questions on and certainly relevant. Clinical presentation. So someone could just come in for a routine office visit and you can find them in AFib. So there may be no symptoms at all. They may not feel anything. They may have palpitations. They may have lightheadedness from hypotension. They may feel short of breath. They may have chest pain. But again, they may have no symptoms whatsoever. Maybe a little dizzy, something like that. Physical exam findings. So we have our irregularly irregular pulse. And the heart rate is like 150 to 200. Labs and studies. So we said that they could have hyperthyroid. So you're going to get a thyroid panel. You're going to get an ECG, obviously. This is diagnostic showing irregular rhythm with no P waves and disorganized electrical activity where P waves should be. And then you're going to get an echo, which is going to show the fibrillating atria and irregular contractions of the ventricles. So you can make the diagnosis with ECG and then sort of prove it with the echo. Treatment. And again, I'm not doing... This is a podcast, so I'm not going to be showing you ECGs. Maybe we'll make a YouTube channel at some point, and that'll be worthwhile. But for now, not going to happen. And I did not go back through and put them on the website. Again, I think there's so many resources for you to find those. Look up Wikipedia. Just type in ECG training. There's tons of stuff out there. So it makes the most sense for you to go somewhere where it's the focus of what somebody's doing. I think you can get a lot more out of it and find questions and things there. That's definitely the way to go. So definitely go look at lots of different examples because AFib in particular can look like so many things. The ECG can just look crazy, but the key is it's irregularly irregular. Oh, so before I go into treatments, let's talk about what that means for a second. So the rate, right? So the rate is going to be irregular, and that makes sense. So it's not going to be one beat or beats evenly spaced, right? The spacing for the ventricular beats is going to be all over the place because what's happening is the atria are sending signals through the SA node. Through the AV node. But the AV node isn't going to let them send 300, 400 signals through. So it only lets a certain number, I don't have it right in front of me, a certain rate go through. So it keeps the heart rate a little bit lower than the 300 that you can get or the ridiculous rate that could otherwise occur. So what happens is the atria are randomly sending those signals down, are constantly sending those signals down, and the AV node lets some through. Well, when it lets them through is when you see that ventricular beat on the ECG, you see that ventricular contraction. Because all these different fibers in the atria are just shooting out their signals, it happened at different timings, so different spacing, so that get through the AV node. I hope I'm making this make sense because I'm I'm using my hands. I'm making everything sound like it looks good to me, but I just so what happens is if the SA node normally under normal situation, SA node fires, AV node picks it up, sends it through. That happens constantly, right? Dung, 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 dung. So you get a very rhythmic, a very regular beat. Now, if the SA node's not doing that, if you get random spots in the atria firing, that comes through at different rates. So one fires, then another one fires. Then one fires, then another one fires, then another one fires. Then one fires, then another one fires. And that's how you get that irregularly irregular beat of the heart rate. What confuses people a little bit, so they understand what irregular means, but why is it irregularly irregular? And we haven't gotten to them yet, but when you get to heart blocks, which we'll do, I don't know if it's next time or the time after that. When we get to heart blocks, those are regularly irregular because what happens is you get beat, beat, pause, beat, 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 pause, beat, or something along those lines. There's different examples, so don't crucify me because that's not perfect. But that's the idea. But those are regularly irregular. So consistently irregular in the same pattern, but not always the same, where with an AFib, it's all over the place. It's completely irregular. And that's important to note and what's going to make it easier to pick out an AFib. So now that you're thoroughly confused, let's talk about treatments. Medical treatments. So we have medical treatments. We've got cardioversion and we got radiofrequency ablation. We're going to start with medical treatments, which is, first of all, rate control. We want to get that rate under control, back it off. That'll help us to get the heart functioning properly. So beta blockers are going to work here. Calcium channel blockers. Digoxin is going to also help in this particular case. You're going to want to give antithrombotics because what happens is, like we said, that heart just kind of quivers. The atria just sort of quiver. They don't push good blood through. And when blood sits for any period of time, it starts to coagulate. So you see this, let's say I'm doing a hysterectomy and we get a little bit of bleeding. And we go about our business because you don't stop every little teeny bit of bleeding. And the abdomen's blown up and we're working on whatever we're working on. And then you come back and there's a little pool of blood. And about 30 seconds later, or however long, you come back and you go to suction it out. And it's no longer a pool of blood, but it's a clump of blood. And this is a blood clot. The blood is clotting off. And that happens kind of rapidly. So if you get this blood just sitting and it's not moving, you start to develop blood clots. And that's what happens in the heart. Now, if you get blood clots in the heart, it's not good, but it's not the end of the world. What happens, the bad part is when those get pumped through and shot out to the brain and they give you a stroke because they clog off some vessel, or they get shot out and they run into the cardiac vessels and they block up the cardiac vessels and you get a heart attack. It's that embolus that is the problem. It's when it shoots down and goes in and blocks distal arteries, and then blood can't get through those. That's where the real problems start to begin. So we give short-term antithrombotics, which is heparin or Lovenox. Those are two short-term things we use in the hospital right away to get coverage. And then we move people onto something like Coumadin, which is more long-term coverage, but it takes a couple days to build up. So we start out with heparin or Lovenox to get somebody started, to make sure that they're properly anticoagulated to begin with, and then we move them off to warfarin. Your goal for your INR for warfarin is 2.5. That might be something else you highlight. You want to keep people at 2.5. We can also do cardioversion. So this is to try to convert them back from AFib into a normal rhythm. You can do electrical cardioversion or a chemical cardioversion using amiodarone or procainamide. And then radiofrequency ablation is something else where you can actually go in and burn some of the atria, and it can reduce that sporadic firing. Yes, I'm sure there are a lot more details I could go into on that, but as far as your exam goes and this show goes, that'll do it. A-flutter is next. Atrial flutter is next. So this is a more organized than atrial fibrillation. More organized than atrial fibrillation. The atria are contracting. Oh, here's where I wrote it down. The atria are contracting at close to 300 beats per minute, but the AV node won't conduct much more than 180 beats per minute. So that's where it gets held up. So even though the atria are contracting regularly, but it's close to 300 beats per minute, that's not going to get through. The AV node slows that down because the ventricles can't handle that. So it slows it down to about 180 beats per minute. Flutter waves are going to be our key sign on ECG. Our clinical presentation, a lot of this is going to be very similar to AFib. Separating those two apart is something you will definitely be asked about. If you type in into Google A-flutter versus AFib, you get a whole lot of discussion because these are things that you're trying to sort of parse out. Routine office visit, maybe with the first clinical presentation, just like AFib, someone just could come in and they're in A-flutter. They don't even know it. They could have palpitations. They could be lightheaded. Shortness of breath and chest pain are also common symptoms. Risk factors are going to be, again, just like they were for AFib, which is they could have no risk factors. They could have chronic hypertension. They have coronary artery disease, valve disorders, or hyperthyroid. Physical exam findings, regular or irregular pulse. Again, typically you're going to see this as a regular rhythm, although it may be irregular. So you don't want to define it as regular, but certainly be looking for it. The heart rate is between 100 and 200 beats per minute, and they may be hypotensive. Labs and studies, you're going to, again, a thyroid panel. The atrial rate on an ECG can be 250 to 300, and the ventricular rate usually about 100 to 150. You're going to see those flutter waves at a rate of about, like I said, about 300 on your ECG. That's the atria contracting. And then the ventricular rate, like I said, about 180. You're going to get an echo, and that should then prove your findings from your ECG. Treatment, same as before. Medical treatment is going to be rate control, beta blockers, digoxin, and calcium channel blockers. So the nice part is, although you have to separate these out in your diagnosis and on ECGs, your treatments are pretty much the same. Again, antithrombotics, heparin, Lovenox, warfarin, INR of 2.5, and cardioversion, electrical, chemical, amiodarone, procainamide, and radiofrequency ablation, exactly the same. They're very similar. They're very, very similar. All right, and then our last one for today is going to be sick sinus syndrome, and then next week we'll drop down to the ventricles. We'll go through the atria, we'll pass through the AV node, and wind up in the ventricles next week. Sick sinus syndrome, also known as Brady-Tachy syndrome, alternating episodes of supraventricular tach and bradycardia. Risk factors are any cardiac history, but especially history of supraventricular tachyarrhythmias, which is kind of what we've been talking about. Advancing age, multiple cardiac medications can cause this, so keep an eye out for that. If you get a test question on this, I would like to think they would have multiple cardiac medications involved. Clinical presentation, pretty much the same as before. Routine office visit, palpitations, lightheadedness, shortness of breath, or chest pain. This can definitely be a routine office visit because these people alternate episodes of supraventricular tach and bradycardia and then normal. So it's not like this is a constant ongoing issue. So another way you may be able to test for it would be with a Holter monitor. We haven't talked at all, I don't think, on here about Holter monitors. Pretty straightforward. It's just a device you wear around your chest, and it takes an EKG 24 hours so that they can be you can monitor someone all the time without having them in a telebed. The issue is, of course, if they don't get a run of this particular rhythm or arrhythmia during that 24 hours, and you don't see it. So it's kind of hit or miss, but it's better than one single EKG. The treatment here is just going to be a permanent pacemaker. They go straight to a permanent pacemaker with sick sinus syndrome. Okay, so our study tip this week, let's move right into that. And my study tip this week, I talked a little bit about this in the emails, and I got some great responses, so I want to go through those as well. The study tip for this week is you need to know your content, right? That's for, that goes without saying. You have to know the content, right? But you need to know some other things, and you need to be prepared for some other things. And one of those things that you need to be prepared for going into this exam is that you need to have the ability to focus. You need to have the ability to use your brain. In the case of the PANCE for 5 hours, in the case of the PAN-RE, 4 hours. Some of you get extra time, so even longer than that. You need to be able to function for that kind of period of time, to be able to read questions, interpret them, and come up with the best possible answer over a 5-hour period. That's really, really hard. I have trouble watching a movie for 2 hours without getting bored and fidgety. This is something you need to be training for, something you need to be thinking about. And I mentioned this a couple weeks ago in the show as well. And I spoke specifically about reading as being a great way for you to build up that ability to read. You've got 5 hours of reading ahead of you. Can you think of the last time you sat and read for 5 hours? I can't. I read a lot. I can probably read maybe an hour, hour and a half is about where I'm done. 5 hours is an incredible amount of time, and you have to do it to get through this exam. So I strongly recommend you start training for things by training up your focus, by training up your brain to be able to focus for that kind of extended period of time. Like I said, I think reading is an excellent source. So yeah, a novel, anything you want to read, but for long periods of time. Novels are great. A while ago, I read, what's it called? The Ghost Map. Really good book. It's about Dr. Snow. I can't think of his first name. I want to say John, but that's probably just because of Game of Thrones and not his actual name. I can't think of it off the top of my head. And it's about a cholera outbreak and how he basically in London and how he discovered what the source of that cholera outbreak was when most of the city believed it was due to bad air. And he tracked it down to one particular drinking pump in the city and showed how the people who used that pump died. And it's really, really good. But anyway, so if you want to do medicine and something that'll help you sort of hold on to ideas, there are books like that out there. The Ghost Map being one of them. But anything is fine. Just read garbage, read trash. Romance novels. I don't care what it is before you go to bed. Read something. Start to build up that stamina, that focus. And then I threw it out to the email list and I said, hey guys, and I gave sort of a discussion on that focus and things you can do and how to help with that. But I turned it around and asked for help from people and said, hey, what are some ideas you guys have outside of reading? What are some ways you can build up that focus? And Megan wrote in and said one of the things you should do is absolutely continue your exercise program. If you're in one, Keep it up. Make sure that you do it. That'll help your mental abilities, help your mental agility, and keep you focused and able to sit longer. And I couldn't agree more. I think that's an excellent, excellent idea. I push that as hard as I can, as often as I can. Exercise while you're studying is just not something to be set aside, but something you should be going after. Another one, which came in from Rachel High from Massachusetts College of Pharmacy and Health Science, which I thought was great, and one thing I never even thought of, was she talks about doing puzzles. That she would sit down and work through puzzles, get 500-piece puzzles, and spend some time sitting with those. And you're going to think you're wasting your time. You're going to be like, what am I doing? Why am I? This is such a dumb idea. What you're doing is getting away from your studying for a little bit, because some of you way over study and burn out your brains. It gets you away from that for a little bit. It gets you to practice your focus. So if you can sit and do a puzzle for half an hour or an hour, and then what you don't realize is the things you're studying are consolidating in your brain with you keeping your brain otherwise occupied. I don't know if that makes sense or not. But while you're working on something else, something not incredibly taxing, but takes a little bit of focus, those insights, those are building. Those neural pathways are building. The connections are forming with the material that you've studied already. And on top of that, you're increasing your ability to focus, your ability to sit and think, which is, like I said, so to me, that's a great one. You're getting a 2-for-1 there. You're getting consolidation of memory, consolidation of things you're studying, and you're practicing your focus. So I can't recommend that enough. I think that's an excellent idea. Thank you so much, Rachel and Megan, for writing in with those ideas. A lot of other people send stuff in, and thank you to you as well. But that's really what I want to talk about this week, was just you need to train for more than just content. Everyone trains content. I really don't believe that people fail this exam because they don't know the content. I think, well, maybe it happens, but I don't think that's the main focus. I think the main issue is people lose focus. I think they get strained. I think they get nervous. I think they get anxiety. I think a lot of other factors come in, and I think there's some things there you can do to deal with that or to prepare for that, let's say. All right, so let's move along. Our post questions. We just have 2 today. What's the INR? What do you want the INR to be when you're treating AFib with warfarin? INR for a patient you're treating with Coumadin for AFib. 2.5 is our magic number. Now, this one you're going to have to do on the honor system. Explain out loud, what does irregularly irregular mean? What does irregularly irregular mean? Explain it out loud. Do your best. Even if I confused you, give it a shot. Because a lot of times that helps to consolidate it. I'm going to give you just a second. Explain it out loud. Even if you're in the car, whatever you're doing, out loud. All right, great. Well, that's it. Wraps us up for this week. Next, we're going to do ventricular arrhythmias. We'll cover that. Those will be our wide complex as opposed to this week, again, was our narrow complex arrhythmias. Next week, we'll do the ventricles, I'm stating, the ventricular arrhythmias, and that will take us out. So good luck to everybody taking their exam this week, and I look forward to talking to you next week. Take care. Good luck.